Okay, let's talk about renal anatomy. We are going to be talking about here renal blood flow and renal anatomy. Okay, so for the renal blood flow, let's look at this picture. What do we have here? So we have the renal artery. It gives off segmental arteries, which gives off interlobar arcuate, lobular, and from there you have this afferent, glomerulus, efferent. Then efferent go to the peritubular capillaries. Okay, so let's read. So left renal vein receives two additional veins. So they're talking about the vein. It receives the left suprarenal vein and left gonadal vein. Okay, renal medulla receives significant less blood supply. Very important. Medulla, it receives less blood supply, blood flow than the renal cortex. Okay, this makes medulla very sensitive to hypoxia and vulnerable to ischemic damage. Left kidney is taken during living donor transplantation because it has a longer renal vein. Okay. One more important point here is the renal artery gets excess O2, so the venous O2 is increased. Gets excess O2. So venous O2. So when the renal artery has so much O2, and you look at the renal vein O2 levels, they're also increased. And you're like, why? It is due to the fact that the renal artery itself it has an excess amount of O2. So that goes towards the vein, and the vein has that. So vein has more O2. The renal vein has more O2 than any other vein. Okay. So for the arteries, you go from all the way from the renal to segmental. If you look at the picture from renal to segmental, the interlobar arcuate, and then after arcuate, interlobular. Those are the small interlobular, and after that small, you have those afferent arterioles, then the glomerulus, because this is at the nephron level. Then the glomerulus, the efferent arterioles, and then from efferent it's going to go to the peritubular capillaries, and from peritubular capillaries, if you follow all of them, it is going towards interlobular vein, arcuate vein, interlobar vein, and finally and eventually going to the renal vein. So this is from renal artery to renal vein. Okay. Let's talk about now the glomerular anatomy. Glomerular anatomy is that you have this going from top, look, you had this afferent arterioles that was coming, right? So afferent arterioles, the blood is coming from the afferent coming, efferent going out. of that nephron, of that glomerulus. Okay, so from afferent arterioles, the blood is coming. Let me change the color to red so you know it's the blood. Blood is coming, and then it is now at this point, it is sensed by the JG cells. JG cells are present from the distal convoluted tubule at the macula densa, and here at the level of as we are entering the glomerulus. But it's going to be mentioned later on too. But from here, in the what is the how do we form the glomerular filtration? Well, that is formed by the look at the from inwards to outwards. We have the podocytes, which is the visceral layer, the podocyte. Look at these podocytes, and then you have the basement membrane. This is the basement membrane. Basement membrane. And the third thing is we have the fenestrated endothelium, fenestrated capillary endothelium. And this forms the glomerular filtration barrier. Okay. And again, from efferent arterioles, it's going to go towards the vasa recta, and then finally all the way towards the renal vein. Okay, so now some other points to keep in mind. One thing is the bladder is extra peritoneal, right? So suprapubic cystotomy will not cross. So the question is, okay, there's the urethral obstruction and there is so much urine in the bladder, okay, and you want to take that out. So you can do suprapubic cystotomy to take that out. But the question is, are you going to cross the peritoneal cavity? Question, right? So the answer is no, you're not crossing the peritoneal cavity when you're reaching the bladder, because the bladder is an extra peritoneal organ. So no, you're not crossing the peritoneal cavity when you're doing this suprapubic cystotomy. And another extra point is urine output and serum creatinine and urea remains normal. It is normal in patients with unilateral kidney disease, because the contralateral kidney, which is working, will compensate for the affected kidney. So the kidney will have to, so basically what it is, so both the kidneys have to be knocked out, basically malfunction, for us to have an increase in creatinine, an increase in BUN. But you can still have hypertension due to either unilateral kidney disease or the bilateral kidney. Both can cause hypertension. Okay, but the creatinine and the BUN would only increase if you have a bilateral kidney problem. So that's all for the glomerular anatomy as well as the renal blood flow.